My name is Kolacek. I'm a pediatric gastroenterologist practicing in Zagreb for already almost 40 years. I trained in Amsterdam and also in Birmingham, and my expertise is actually short gut syndrome, intestinal failure, and I am participating in this perioperative nutrition together with my team here, and it's a great pleasure. Thank you for the invitation. So here are my disclosures. Just to summarize again, we are facing still often this historical perspective that food is really not desirable in the gut for days. One day before, because we are afraid of aspiration and pneumonia. For days after the surgery, because we hear that the motility, particularly the gastroduodenal motility, is so impaired that we will run into ileus and aspiration and diarrhea afterwards. And if the food is there in the intestine, that it will be increased chance of anastomotic dehiscence. So first, again, to repeat, do we need to fast? 40 years ago, actually, you can see on this left side figure that clear liquids leave stomach within 1 hour. And the Cochrane review already more than 15 years ago confirmed that children who were on unlimited clear liquids up to 2 hours preoperative had no increased rate of complications, were more comfortable, less thirsty, hungry, irritable, so better behaved. However, if they were permitted solids up to 2 hours before the operation, they had a higher gastric volume and food particles in the aspirate. Preoperative loading, so less nausea, and they had less gastric content. So what could we actually recommend? A little bit different than what you, Katrin, showed. For the latest guidelines, clear liquids are allowed, according to the recommendations, up to 1 hour preoperatively. Up to 16 years, breast milk, this is the same. Breast milk allowed until 4 hours before, and milk and solids 6 hours before. So just this 1 hour is a little bit changed. So first, in respect to preoperative fasting, not anymore advocated, clear liquids until 1 hour, and the carbohydrate clear liquid loading seems to work in children. We will now see the evidence when to start feeding post-surgery and what mode and type is preferably. First, huge meta-analysis done in adults, 3 in different time periods. I have summarized here the results for you. 2009, 11, and 19. They did confirm in more than 1,000 patients in each of the meta-analysis that mortality, total complication, and the length of hospital stay were decreased if the food was provided within the first 24 hours. And on the other hand, that there was no increase, as it was anticipated historically, in wound infection, pneumonia, anastomotic dehiscence, and anastomotic leak. However, the studies are not of the best quality and the best randomization, but it is a difficult model. Again, I was really surprised when I looked at the studies that we do have a meta-analysis in children. It just appeared online, 10 trials, more than 1,200 pediatric patients, and those at early. And early here meant not first 24, but 48 hours, compared with after first 48 hours, significantly decreased any complications, septic complication, wound infection, time to first stool, and length of hospital stay by almost 3 days. There was no difference in anastomotic leak. If you look at the data, almost significant in less anastomotic leak in those who received food earlier, no difference in dehiscence, abdominal distension, and vomiting. You might say yes, but this was in the first 48 hours. Another study, not randomized, a retrospective study collecting children after cardiac surgery who received early enteral nutrition within 6 hours and those after 24 hours. And you can see that the number of patients reaching target caloric intake was significantly better in those who received food within the first 6 hours, that the post-operative staying time was significantly lower, and also the total length and the complications were no different between them. There is a meta-analysis in adult patients comparing enteral nutrition versus parenteral nutrition after gastric surgery. You are aware that until 10 years ago, we were really advocating and pushing, if not enteral, with parenteral nutrition. Yet this study, which was meta-analysis, which was published 15 years ago, showed clearly that providing parenteral nutrition increased complications, infectious complications, anastomotic leak, intra-abdominal abscesses, and length of hospitalization. And it is not completely clear why the abscesses and infectious complication. It might not be clear, but I will describe it later. As for that, we have heard about the ERAS in children, but also just now appeared a systematic review and the meta-analysis looking at the role of food within the ERAS project. And you can see that 16 studies, 1,700 recruited children, and those who did receive early enteral nutrition within the ERAS project had significantly reduced time to initiate enteral feeding, significantly reduced time to reach the full enteral feeding, length of hospital stay, and no difference in the readmission rate. Seems that septic complication, infection are less common in early, and that enteral nutrition works in that respect better than parenteral. So the question is why? In all of us, not in a surgical patient, occurs bacterial translocation. And for those who are not familiar, it is the passage of bacteria from the lumen through the enterocyte into the systemic circulation. And we thought first that it occurs only in the severely sick patients, yet it occurs in us, particularly after the meal as well. But however, there are predisposing conditions when it occurs in a higher rate, and this is reduced blood flow, parenteral nutrition and fasting, in the other words, empty gut, hypoalbuminemia, antibiotic treatment, and anti-acid medication. We are looking at this surgical patients after the surgery in the intensive care units, splanchnic hypoperfusion together with empty gut, ischemia reperfusion injury, inflicting inflammation, loss of gut barrier function, and the massive bacterial translocation, massive release of pro-inflammatory cytokine, entering the systemic circulation and closing the vicious circle. You might say, okay, but we are here dealing, if we have a splanchnic hyperperfusion, we are dealing with the serious patients and cannot be fully fed within the first day. We know already for 20 years that even providing minimal so-called trophic, because it is feeding the gut, oral intake normalizes the release of Coleman's neurotransmitter, normalizes the propulsive motility, increases the blood flow, and improves the mucosal barrier function. And it has been shown in the preterm babies that the culture confirmed sepsis, C-reactive protein, length of parenteral nutrition, time to full enteral feed, everything was decreased in those who received trophic feeding. You might say these are the preterm babies. It will increase the necrotizing enterocolitis. It did not, although the abdominal distension occurred more commonly. So this trophic feeding worked. So it seems that we need to provide even minimal amounts into the gut to establish normal pattern of gastric motility and absorption. It seems that early enteral nutrition works and within the first 24 hours, and that parenteral nutrition should be reserved only for those who do not tolerate enteral intake. As I said previously, we would push because we thought that children are in the state of catabolism, yet we are not anymore pushing for parenteral nutrition. We push to start, even with minimum amounts, promote increase in easily digestible foods, and only if the children cannot be fed for more than 7 days, parenteral nutrition is advocated. And the reason for it is that in catabolic phase, despite catabolism, which is due to autophagy, it is not that the requirements are increased, they are actually decreased, and the patient provides and covers for up to 75% of requirements in the acute phase due to the nutrients released due to catabolism. And therefore, to prove that, this study published in New England Journal of Medicine, international multicenter trial, almost 1,500 critically ill-term children, and intervention was PN provided within the first day, as we used to do, together with the increase in enteral nutrition, compared with just pure rehydration. Here you see the liquid and micronutrients and slow increase in enteral nutrition. And the outcome, patients were randomized, and those who were in early PN had the increased stay in pediatric intensive care unit, significantly increased rate in infection, airway infection, bloodstream infection, time on ventilator, kidney failure, stay in hospital. Hypoglycemia has been increased, but not the refractory one, and readmission rate was actually no different. So currently, we do recommend in our latest PN guidelines that we published a couple of years ago that withholding PN for 1 week in critically ill is advised. This area here, acute, when the energy is produced by catabolism, by autophagy. Yet we have this recovery phase here and this period to start anabolic phase, although we are not clear where is it exactly, but it comes earlier in children than in adults. And in this recovery, the normal caloric requirements double to triple in respect what was the severity of the operation and how severely malnourished the patient was. So the nutrition requirements increased markedly during the recovery phase, at least 2 times, and therefore the prolonged intensified nutritional support, the weeks to months, plus mobilization and exercise are required in children for catch-up growth. How to support them, counseling about nutritional dense food together with the oral nutritional supplement. Already, if they receive it within the hospital, in a big USA study comparing patients who did receive it matched to children without oral nutritional supplement, cost that it decreased the hospitalization and decreased the hospital costs, so it was cost effective. So just to summarize, the carbohydrate loading seems to work in children, and the children can have clear liquid up to 1 hour before the anesthesia, that in the gut, the nutrients are beneficial, even in a minimal amount, that the PN is reserved only for patients that do not tolerate it for a longer period after the surgery and should be avoided in the critical ill patients in several days after the operation, and that we need to think to support the catch-up growth, we will need weeks to months of intensified dietetic support and providing oral nutritional supplement. Thank you again for your kind attention.
I am a pediatric dietitian and I've been at Texas Children's for about 15 years, and about a decade of that was in our pulmonary clinic doing a lot of work with that population, and then have been involved with our neuromuscular multidisciplinary spine surgery population for 6 or so years now with them. So the objectives, I'm going to talk a little bit about some of the unique challenges the neuromuscular patient population presents, talk about some best practices, some barriers, and then some opportunities. For patients that have neuromuscular scoliosis, they do typically have some kind of an underlying medical condition, whether it's cerebral palsy, muscular dystrophy, SMA, or Rett syndrome. So they do already have some complications or some underlying medical conditions that may complicate their pre and post-op course. So they might have increased energy needs because of this underlying medical condition, or they might actually have decreased energy needs because of their condition. Because of their underlying medical condition, very often they do have dysphagia and or dystonia, which means that they either, need some kind of an altered diet as far as the particle size of their food, thickened liquids, or they might have a limited ability to actually feed themselves, to get their hands up to their mouth effectively to feed themselves. So they might rely on caregivers quite a bit in order to receive their nutrition. A lot of these patients are non-ambulatory, so they are already prone to having some compromised areas of skin integrity and maybe at risk for skin breakdown, particularly as they are recovering from their surgery postoperatively. Wound healing is something that we are looking at in this population. So a lot of factors that may make this a little bit more challenging in this population. We've been talking about nutrition screening, which I really love. And a lot of nutrition screens, one of the core features is having some objective measurements in order to determine somebody's nutritional status. And typically you're getting some measurement of anthropometrics, heights, weights, that kind of thing. It can be really hard to get accurate heights and weights in this population. If the patients are non-ambulatory, you really need to have special equipment to get a proper weight, either in a sling scale or having a scale where you can wheel on the wheelchair, take it off, and then take the weight of the wheelchair. So you do need a little bit of equipment in the right place where you're seeing the patients to get an accurate weight. Getting a height can be very challenging in a non-ambulatory patient, but particularly one that has some significant scoliosis. So even if the patient is ambulatory, a standing height might not be very accurate, and you need to then rely upon some other alternative height measurements. So there are other ways that you can estimate height, but I don't know that we really understand what is maybe the best way of estimating height in this population. So that might be something that we can think about in this group. So because of those reasons, BMI might really be a poor indicator of their nutritional status, because if you don't have a good weight and a good height, BMI is not going to tell you anything that is particularly helpful or may reflect their nutritional status. So an alternative measurement could be mid-upper arm circumference, might be a good alternative to looking at somebody's nutritional status. Aside from anthropometrics, Dr. Kolacek mentioned earlier the subjective global nutrition assessment. So I cannot emphasize enough the importance of doing a physical assessment on a patient to look at their reserves of adipose and lean body tissue to determine their nutritional status. It's really essential in this population. Other things to look at is their intake, how we can optimize their intake orally or enterally. A lot of the patients do already have a G-tube, but we do have a lot of patients, just because of the nature of our institution, that are coming from other places that may not have had access to a dietitian regularly and do have some chronic, moderate to severe malnutrition that probably should be addressed well before the surgery. And then on the flip side, we have already discussed this, but obesity can increase the risk of complications related to wound healing. And this is, certainly true in this population as well. A picture is worth 1,000 words. So this image is courtesy of Musculoskeletal Key and really kind of puts a good perspective or picture in your mind about when you're thinking about these patients, what limitations that might have. Some of it could just be their physical body positioning preoperatively and just their limited ability to optimize their nutrition orally or enterally, depending on how their curvature is affecting how they're physically oriented. And then the surgery can be quite extensive and lengthy, typically 6 or more hours. So it is a significant amount of time in the OR and metabolic demand being put on these patients. Even if they are, at marginal nutrition status, this is a really significant surgery. for these kids. Currently, the mid-upper arm circumference can be a more sensitive indicator than BMI. And we already discussed that BMI might not be a good indicator in this population anyway. So maybe we need to be looking at the right metric in this group. In adults that are malnourished, the typical 7 to 10 days or 14 days, as we had said, is extended up to 2 to 3 weeks, but that's in adults. In kids, we don't really have a time metric that I was able to find to optimize nutrition in malnourished kids, but if you're able to get their BMI Z-score above -2, that is better. Is it good enough? It's hard to tell, I think. And then, of course, since we're dealing with orthopedic surgeries, we're, concerned about the status and quality of the patient's bone health. And so this population does have a significant amount of vitamin D insufficiency, up to 75% in one study that I found. So they could be going into this surgery with some deficiencies that really wouldn't be helpful for them as they're recovering from their orthopedic surgery. We've already talked about minimizing fasting, and the same kind of applies to here as far as the current evidence that was found for the US anyway. And then it seems like in Canada and Europe, the clear liquids is reduced to 1 hour prior to surgery. There is also an increased probability of getting a transfusion for pediatric patients that have a low BMI. And of course, wound infections also with a poor nutritional status. So the goal would be to resume nutrition within the first 24 to 48 hours for the reasons that we've already covered related to length of stay, infection rates, and preventing an ileus. We, of course, do prefer enteral nutrition over parenteral nutrition. However, in this population, since a lot of the patients are really often borderline in their ability to take food in orally, it can be exacerbated for them after surgery. So this population really might benefit from getting an NG2 placed at the end of their procedure if you really feel like they're not going to be able to consume a nutrition supplement orally or resume a diet orally if they are already marginal eaters prior to the surgery. And then, of course, if enteral nutrition is not feasible or able to be initiated or advanced by day 5, we should start considering parenteral nutrition, but that does come with risks, particularly for infection. We really would prefer enteral nutrition over parenteral nutrition, but even some trophic feeding would be beneficial. So if we could get that in conjunction with parenteral nutrition, that would be more ideal. For our best practices, we do have a neuromuscular spine surgery care plan. And there is a process for our patients to go through for their spine surgery. There is an initial indication meeting to evaluate their need for surgery. If they are approved to go through a multidisciplinary process, they do receive some consultations. All patients will receive pulmonary and nutrition consultations. And depending on what is brought up during that indication, they might have other ad hoc consultations by cardiology, hematology, et cetera. They then go to our pediatric anesthesia screening clinic or PASS clinic and meet with our anesthesia team initially. And then they come back after all the evaluations have been complete for a second meeting that we call our multidisciplinary review, where their pre-op workup is discussed. And if they are approved for surgery, then they go back to PASS number 2 just prior to their surgery date. So the multidisciplinary team is a group of physicians with a variety of disciplines in orthopedics, neurosurgery, pulmonary anesthesia, hematology, and critical care. And there are ancillary staff as well on this multidisciplinary team, including nurses, dietitians, and then some of the OR staff, such as neuromonitoring. While we don't have a clinical pathway, we do have an order set that we utilize to help to standardize our care during the hospitalization. So some of our best practices are we very often have a delayed surgery until nutritional status is improved. It can take quite some time for patients that are coming to us with moderate or severe malnutrition to get rehabilitated enough to proceed with surgery. So that delay, of course, can be critical, especially if their scoliosis continues to progress while we're waiting for the patient to gain adequate weight to optimize their nutrition status so they can have their surgery. So that has been a big challenge for us and for the patients. Some of our patients do go into the hospital about a month before their surgery for traction, and this is actually a great time to continue to optimize their nutrition preoperatively. So we do take advantage of that if that is one of the methods used for that patient for their surgical course. We do try to initiate or resume nutrition within 24 to 48 hours post-operatively. And if the patient, like I said, does eat orally and they will likely not be able to consume either food or supplements orally, we do put in an NG tube. And this is a conversation that we have with the family preoperatively to see if what they feel like the likelihood is of their child being able to eat. And, while they are optimistic, they do want to be more conservative with the whole process. So we do encourage NG tube placements if nutrition will be a challenge by mouth. For those patients that do have dysphagia preoperatively, we do encourage bedside swallows with our occupational therapists or speech therapists as they are resuming their oral diet, especially for patients that have scoliosis higher up, where they might have changes in their body positioning postoperatively that might change how they are able to chew and swallow. And this is something that we have incorporated, particularly for that population. They, of course, do have some increased protein needs among other micronutrients. We have used typically aspirin, but this is more for critical care. And so what was optimal for patients postoperatively for surgery, I think could be another area where we could do more research to see if those protein recommendations are targeted or could be used for this population, or if we need something a little more customized. Of course, more aggressive nutrition for wound healing. And all of this is really important to talk to the patient and family about before they go into this surgery. It's, post-op day 0 or 1 is really not the time to be having these conversations. There's a lot of other things going on. And typically these patients are in our ICU afterward because they are high risk and very complicated. And so it's really not the time to be having these conversations with the family on what they want to do with their nutrition. So it really needs to happen ahead of time. Some of the barriers could be communication or cognitive limitations or impairments with some of the neuromuscular population. For some kids, giving them prompts and encouraging them to eat or drink is effective. And for other kids, it's really not going to be effective, especially if they're able to communicate what it is that they're feeling, whether they're nauseated or having pain. It could be very challenging to have that communication with the patient. Like we've talked about earlier, there is really no screen specifically for pediatric surgery. So we'd be needing to evaluate some of the existing screens to see if some would work or come up with a entirely new screen or have a dietitian see every patient, which in this particular population, every patient is seen by a dietitian. It can be very challenging to obtain accurate anthropometrics in this population. So having some identified surrogates for looking at nutritional status would be really helpful to track over time. For example, the MUAC or physical assessment. We kind of mentioned earlier about the carbohydrate loading. While there have been some groups that have started utilizing carbohydrate loading, I don't know that this is really widespread, in particular, not in the neuromuscular population. There are no dosing guidelines in this condition. A barrier is changing the mindset of the physicians that would prefer to utilize parenteral nutrition over enteral nutrition. Again, a lot of our patients are going to the ICU after the surgery in this group. It can be very challenging to discuss utilization of enteral nutrition in this group. So doing education and work with the critical care team would be very helpful, I think. Since this patient is largely non-ambulatory, they're not able to have early mobilization that is typically encouraged to help prevent postoperative ileus. So they really don't have that capability by and large. So that is really something that is a barrier for this population. And then, of course, a lot of these kids have some kind of dysmotility at baseline due to their underlying condition. And this can just be exacerbated with pain management postoperatively. And if they are getting treatment for constipation management, and if it goes a little too far and they start having diarrhea, a lot of these patients are wearing diapers. And so they do have a risk for having some of the translocation of that fecal matter into their surgical wound site. If it goes, lower onto the spine, that can be a concern as well. So some opportunities for research could be trying to identify nutrition indicators that really reflect patients' nutritional status and how those can be linked with the outcomes, such as length of stay, surgical site infections, readmissions, and transfusions. We've mentioned screens, so identifying a proper screening tool to identify patients that are going to be at risk, including some carbohydrate dosing or other recommendations for this population. A way of managing some of the GI dysmotility and constipation management that can happen, particularly with pain medications post-operatively, and also to create a care algorithm or clinical guideline for this group. Really hands-on education to obtain anthropometrics is essential. You really just have to go in and teach somebody how to do it and to do it repeatedly to be able to get accurate anthropometrics. Training in that area will be very helpful. It's really important to talk about post-operative nutrition with the whole team and patient and family well before surgery to try to minimize the use of parenteral nutrition, and education with the physicians on the benefits of enteral nutrition over parenteral nutrition, I think, is important. And then collaboration with any other ancillary staff that might be helpful with rehabilitating the patient post-operatively. Their dysphasias such as occupational speech therapy would be great. And then communication, education, and collaboration with every member of the medical team, I think, is essential.